Assalamu alaikum wa rahmatullahi wa barakatuh. Uh, Dear students, I hope you are all doing well. First of all, to check, is the quality of the voice clear to you? You can hear me clearly? Okay, I assume yes. Okay, good. So, if you still remember, in the previous lecture, lastly, we have finished the respiratory system. And if you still remember, the part of the respiratory system which is shared with the gastrointestinal system was in the upper pharynx region. So in the pharynx, if you still remember, this part is a shared part between the respiratory system and the gastrointestinal system. Not all of it, only the oropharynx. So in the oropharynx, which is in the middle of the pharynx. Above the oropharynx, we have the nasopharynx. Below the oropharynx, we have the laryngopharynx. Both nasopharynx and laryngopharynx were part of the respiratory tract, while the oropharynx is a common or shared place between the gastrointestinal and the respiratory system. So from that part was the first introduction to the beginning of the gastrointestinal system. Well, today we are going to go into more details about the anatomy and physiology of the digestive system. We will start from the upper parts in the same approach we have used in the respiratory system. So, the learning outcomes are very simple. We will identify the components, the anatomy of the different organs within the gastrointestinal system. We will try to describe the gross anatomy, the structures, the histology of these organs, and then we will go into the function of each one of these, describe it in details, and in addition to these, we will describe some accessory organs in the digestive system which help. Accessory means they are assistant. So they help in the function of the gastrointestinal system, and these will also be described, including the liver, the pancreas, the gallbladder, and the salivary glands. So, before starting with the gastrointestinal system, if you still remember the surface anatomy of the abdomen. Now this part, which has been already covered in the beginning of HSF1, in the first few lectures, we have described the regions within the abdominal, the abdomen, okay? And again, I would like to highlight the importance of this slide for you because, again, some of the multiple choice questions might include this figure. So what you need to understand about this figure is that, first of all, you need to know the names of the regions. So there are two classifications, but we are using this one. So as you can see, the abdomen is divided into 9 regions by these 4 lines. 2 of the lines, the vertical ones, are being drawn from the mid-clavicular. Mid-clavicular, sorry, I'll try to make a pointer. Okay, so these 2 mid-clavicular lines, the left and the right, are drawn from the middle of the clavicle. If you know the clavicle, the bone in the which attached to the upper border of the sternum, and then it runs laterally, okay, and joining the scapula. So this mid-clavicular line runs from the middle of the clavicle downward, okay, and we have the left and the right. Those are the 2 vertical lines, and the 2 horizontals, one of them is the subcostal running through the 4th disc between L1 and L2, and then the lower line, transtubercular plan, which is at the level of L5 between the tubercles, okay. So these 4 lines will divide the abdomen into these 9 regions: the left hypochondrium, the epigastric region, the right hypochondrium, the right lumbar, the left lumbar, umbilical region, right inguinal, hypogastric region, left inguinal region. So usually in the quiz or in the questions, it will either tell you about one organ, and then it will tell you about which one of the regions are corresponding to the location of that organ, or the opposite. It will tell you about a special location, and then it will give you which of the following organs are corresponding with this abdominal region. So the right hypochondrial region is the most important organ to be mentioned here is the liver. Okay. In addition to the liver, the gallbladder, but the liver comes first. Liver extends from the right hypochondrial region to the epigastric region. But if you are supposed to select one, you go for the right first, because majority of the liver lies in the right hypochondrial, with a small part, okay, within the epigastric region. The epigastric region, part of the liver, but the most important organ to remember here is the stomach. So even the gastric problems, the epigastric, so from the name, epigastric. So the gastric is the term used to refer to the stomach. So here it is important to remember the stomach. While in the stomach, by the way, also extends part of it, like the liver, to the left hypochondrial region, but mainly it's in the epigastric region. Here in the left hypochondrial region also, the spleen exists over this side. Now going down into the umbilical region, in the upper part of the umbilical region is the transverse colon, mainly the small intestine. That's why most of the colicky, abdominal pain due to small intestine disorders is usually felt in this area of the abdomen, the central umbilical region. While less likely the right and left lumbar region, they are less likely to show any symptoms in cases of gastric problems. However, the location of the ascending colon and descending colon are in this region, but these regions usually correspond with problems in the urinary system, okay? Especially if the pain will be toward the back, because of the renal organs are retroperitoneal organs. They are posteriorly situated, and there is a difference between the location of the organ and the pain or the sensation which is felt, which usually happen due to the sharing of the same nerve supply. Anyway, here the location in the right and left are the ascending and descending colon, as we mentioned. Going down into the right inguinal region, here the most important part in the right inguinal region is the appendix. And looking in regard to the appendix, because it's inflammation of the appendix is one of the commonest surgical or the abdominal emergencies that come to the hospital. So here you need to remember that this is the appendix region. Hypogastric region is where problems in the lower renal system happen. So lower urinary bladder problems usually are associated with this region. Left inguinal region here might be involved, especially with the ovaries, right and left, by the way, in females, but it is less significant in male. All right. So again, I will tell you to focus about this slide. So here there is another figure showing you the distribution of the different organs of the gastrointestinal system. Now we will reach to the functions of the gastrointestinal tract. What are the main functions here? So the first, just if you try to make it logical functions of the gastrointestinal tract is ingestion. The first thing starts when we ingest food, and then following ingestion is propulsion, which is the movement of the bolus of food from the mouth down in the intestinal tract. In addition, with this propulsion, we have mechanical breakdown, which is the grinding, the breakdown by mechanical movement of the food particles. And then we have the chemical breakdown, which is the digestion. So that's another function of the gastrointestinal system. This is accompanied after it is completed. The food is ingested, propelled, broken down, digested, then the absorption starts. So this is another function of the gastrointestinal tract, absorption. And then the leftovers after absorption will be defecated out from the gastrointestinal tract. And in addition to all these six, which are closely related, comes one additional function, which is host defense, like what we have described in the respiratory system. So we have a defense system in case of the ingestion of any contaminant, chemical or microbial contaminant. The body has its own defense lines within the gastrointestinal system. And of course, these includes the acids and the immunoglobulins, the lysozymes, which are help to eliminate microbial agents, in addition to the acidity of the stomach, which helps to kill the bacteria and other microorganisms. Okay, so as you can see into the figure, you can see the functions. So first, ingestion, which starts by chewing and swallowing. That's the number one. And then the propulsion, propulsion is the mechanical movement of the food particle, which includes the swallowing, and the movement of the gastrointestinal tract, which is very characteristic here, and it is known as peristalsis. So in peristalsis is a special type of movement within the GI tract, mainly in the intestines and the stomach, esophagus as well. This movement will help to move the food particle in one direction, which is downward, from the pharynx down through the esophagus to the stomach, from the stomach to the small intestine, to the large intestine, and out through defecation. So this is all peristalsis. Okay. In the swallowing only happens in the upper part of the gastrointestinal system. So these together are within the propulsion. The mechanical breakdown, as you can see here, includes the chewing that happens in the oral cavity, the churning by the stomach, which is a grinding, powerful breakdown of the food inside the stomach. And in addition, in the small intestine, we have segmentation, circles of constriction that happen within the small intestine that will help in the mechanical breakdown of the food particles. And then starts the digestion. So in digestions, of course, it includes the release of digestive agents, which are including most importantly, the enzymes and hydrochloric acid. For example, in the stomach, we have some proteolytic enzymes which are released in the stomach as well. We have carbohydrate digesting enzymes secreted in the oral cavity. There is no digestive element secreted in the stomach, in the esophagus. So the oral cavity secretes some digestive elements, lipases and amylases, which helps in the breakdown of lipids and carbohydrates, while the protein, so the beginning of carbohydrates digestion starts in the oral cavity. That's why, for example, if you are having some headache due to hypoglycemia, once you take a piece of sweet and you start chewing that sweet within the oral cavity, you feel the improvement of the condition, and the blood sugar level slightly goes up. So part of the absorption happens within the plexus of blood vessels within the oral cavity, and digestion also starts in the oral cavity. While in the esophagus, it will mainly it starts with swallowing, and then the food part or the chyme will be propelled down to the stomach. So its main function is actually for conduction, like the trachea, like the upper respiratory tract. It will propel the food particles to the most powerful, important digestive organ in the gastrointestinal tract, which is the stomach. And of course, the esophagus helps in the conduction. In addition, it has some protection sphincters in the upper and lower region, preventing anything going up into the respiratory tract, preventing anything going up from the stomach to the esophagus. But there is no digestion here or secretion of enzymes from the esophagus, mainly mechanical propulsion peristalsis, that is moving the particle down into the stomach. While in the stomach, we have some the mechanical movements, as we mentioned, the kerning movement that we have described, and in addition, of course, to the peristaltic movement, which also happens in the stomach. And we have the secretion of the digestive agents, the hydrochloric acid. We know the stomach is the part of the gastrointestinal tract which has a very acidic environment compared with other parts. We know the pH in the stomach goes very low, and that pH does not exist in other parts of the intestinal tract, nor in the esophagus, nor in the oral cavity, even in the intestines. Every place in the gastrointestinal tract, the pH is neutral, slightly alkaline, or slightly acidic, but it is only very low and highly acidic in the stomach by the secreted hydrochloric acid, which plays a very important role in the digestion of proteins. And then, of course, the food, once it's digested, breaking down mechanically, chemically, enzymatically, then it will be through peristalsis pushed into the small intestine, which is the first part, the duodenum. And in the duodenum, the secretion of digestive elements continues, in addition to the accessory secretions coming from the liver, gallbladder, pancreas, which will also join the food particles here in the beginning of the small intestine. And the condition of digestion continue by the secretions by all these elements. And starting from the second part of the small intestine, the jejunum, starts the important and the majority of the absorption. So after all this digestion, absorption happens in the small intestine. Okay, so in the small intestine, there is some digestion, especially in the beginning, and most of the absorption will happen in the later two parts, the jejunum and the ileum. And then the food will be propelled through all this long way of absorption, which is around 3 meters long. And then once the food reaches into the large intestine, in the large intestine, there is no more digestion. Only the absorption continues in the large intestine, and afterwards what is left from the absorption is going to be waste that is lost through defecation. So the host defense is actually related to some of the secreted immunoglobulins, IgA, local acting immunoglobulins, which helps to protect the mucosa of the gastrointestinal system from penetration and infection. In addition to this, the acidity, as we mentioned before, which also helps to protect the gastrointestinal system. In addition to these two, we have lymphatic tissues which present in the upper parts of the digestive system. For example, the pharyngeal region. We have the pharyngeal tonsil, the adenoid. We have the lingual tonsil. We have also the lymphatic vessels or lymphatics running through all parts of the gastrointestinal system. We have the Peyer's patches. We have the special lymphatics also present in the omentum, which is in the covering the anterior border of the abdominal cavity. The appendix is also a collection of lymphoid tissue. So all this lymphoid tissue helps to protect the body as a host defense against invading microorganisms. So these are the functions of the gastrointestinal system. So the parts we already went through. We have the oral cavity, the pharynx, which is part shared between the gastrointestinal system and the respiratory system. Then, after the pharynx, esophagus, stomach, small intestine, large intestine. Now, these are the main organs. We have accessory organs, salivary glands. Those glands are present in the oral cavity, secreting saliva. So saliva is that liquid, clear liquid, which is secreted from these exocrine glands into the oral cavity, have a digestive role in addition to the immunological function. We have the liver, the pancreas, and the gallbladder, as we mentioned earlier. So starting in the oral cavity, very quick description. You can see here the upper jaw and the lower jaw, the upper lip and lower lip, which are part of the orbicularis oris muscle. Okay, and we have the upper jaw, the teeth, the roof of the oral cavity, which is hard in the anterior aspect, called the hard palate, while posteriorly there is no bone, and it is known as the soft palate, which will make a projection known as the uvula, mostly important in the production of sounds. We have the tongue, which is important for the special sense of tasting. In addition, it helps in the propelling the food particles into the pharynx for swallowing. Okay, the uvula, as we mentioned, in the base of the tongue we have a flap of soft tissue that attaches the lower aspect of the tongue to the floor of the oral cavity, called the lingual frenulum. In some people, this frenulum might be short, leading condition known as tied tongue, which causes speech defects. Okay. We have the tonsils here. These are the palatine tonsil. We have two on either side. Those which are usually examined using the tongue depressor when you even go for any checkup with the physician. Usually one of the first things that being checked are the tonsils to indicate any infection within the pharyngeal region that will cause inflammation and enlargement of these lymphatic organs. So there are two arches. The one which is anterior, G here, is the palatoglossal arch. It is within the palate. And the one which is more posterior is the palatopharyngeal arch. So these are the two arches, and in between these two arches there is a fold, and within that fold lies the palatine tonsil in the lower aspects of this fold. So back into the same part, these are the same things. The hard palate, as you can see, which is the floor of the nasal cavity that we have described before, and then the soft palate and the uvula in the last lower part of the soft palate, and then you can see the two folds, E and F, the palatoglossal arch and the palatopharyngeal arch, and the fold in between where the palatine tonsil exists. And then in F, behind F here, okay, this is the oropharynx, if you remember. And from the oropharynx and lower laryngopharynx, then this region is shared between the upper larynx and the beginning of the esophagus. So a very quick description of the teeth. We have the incisors, two on either sides. So we multiply by 4 for both jaws, upper and lower. And we have 4 canine bones, teeth, 1 on either side, so 2 in each jaw. And then we have 2 premolars on each side, followed by 3 molar teeth. Usually the last molar is the last one to appear after adulthood. And these teeth in children, which start to appear by the age of 6 months and complete by 2 years of age, are the baby teeth or milk teeth or deciduous teeth, and then they start to fall off between 6 years and completely fall off by 12 years. And usually with their fall off starts the appearance of the permanent teeth, which happens usually during the adolescence period of age. And this classification of the teeth is based on their shape and their function. The incisors are mainly for cutting, while the grinding is mainly by the premolars and the molars, and so on. So a very quick look into the structure of the tooth. So the apparent region above the gingiva, okay, is the crown. Okay, this is the part which is apparent that could be seen. There is a neck region, that part which is within the gingiva, and then the root, which is penetrated through the alveolar bone of the upper and lower jaw, the mandibles and the maxillae. Okay, so here you can see the root which goes into the bone, and it is the root is surrounded outside by the cement, which is a special type of calcium salt that attaches the dentine material of the teeth to the periodontal ligaments. Okay, and then in the middle of the teeth we have the pulp cavity, which involves the blood vessels and nerves. Okay, and the dentine makes the majority of the teeth material. On the surface of the teeth we have the enamel region, which has slightly different composition, which is much harder compared with the dentine material. Here it has more calcium salt, less water, less organic, while the dentine has more water, more organic material compared with the enamel. And we all know that the hardest part of the teeth is this white enamel shiny area that covers the apparent part of the teeth. Okay, so in the oral cavity we still the salivary glands, which is the first accessory organ of digestion in the digestive system, and we have three pairs, right and left, three. So we have the parotid, which exist in the anterior to the ears, okay, on the sides of the cheeks. And these glands secretion mostly are released through the upper jaw into the oral cavity, while in the lower jaw we have both sublingual, which is below the tongue, and submandibular, which is slightly below the mandible, the lower jawbone, and the secretions will go again also into the oral cavity. These three lingual glands, which exist in pairs, will secrete their contents into the oral cavity, playing a role in the beginning of digestion. So here the very introductory detail about the content of the saliva. The water, which is around 1 to 2 liters of secretion per day, which will be reabsorbed back in the small intestine. And again, to mention here, the secretion of the saliva is under the autonomic nervous system. We will go into the mechanisms and the reflex that controls the secretion of the saliva later on. So the contents are water, the mineral salts, the chloride, which is very important for the activation of the amylase enzyme. Immunoglobulins, IgA, is secreted by the salivary glands, and these glands are exocrine glands, which means they secrete their products through ducts. So these are, you can see the ducts of the parotid and the ducts from the sublingual and submandibular into the oral cavity. So they are duct glands with ducts. That's why they are exocrine glands that secrete their products into the oral cavity. So again, the saliva, mixture of mucus and serous fluid, helps in the beginning of digestion in the oral cavity, while the food is being chewed, masticated, mixed with the saliva, and it contains the salivary amylase. Amylase is the enzyme which breaks down carbohydrates, Okay, it works on a special type of bond present in polysaccharides, including starch and glycogen. Okay, so breaking it, it will break down these large carbohydrate molecules into smaller oligo on disaccharides that will be further digested later on in the digestive system. Lysozymes, which have a defense mechanisms, IgA again also a defense mechanism. And here the pH in the oral cavity is not very alkaline, it is neutral to slightly acidic. Okay? And the volume, as we mentioned, is 1.2 liter per day secreted, 1 to 2 liter, by the way. So the control of salivation is mainly by a special center, a salivation center that exists within the medulla oblongata, the same place where the respiratory center exists. So now you can see that many vital centers are located within the medulla, and we will continue mentioning about other vital centers which also exist within the medulla oblongata in the brainstem region. So here, this center, if it is activated, it will cause the reflux of salivation, which is mainly through the 10th cranial nerve, through an autonomic action, a parasympathetic system, through the autonomic nervous system by the vagus nerve, that will stimulate the salivary glands, causing increasing salivary secretion. Now, what could stimulate this? Of course, part of the stimulation is once the food is inside the oral cavity. The pressure receptors, the chemoreceptors that are sensing the food inside your mouth will stimulate the salivary center in the medulla, and this will cause the vagus nerve to stimulate the salivary gland, secreting the saliva that will start. In addition, the salivary center could be stimulated by cerebral cortex and other inputs. For example, thinking about food can increase salivation. Smelling food can increase salivation. Sometimes even certain sounds which are related with the tradition of eating, they had run a special experiments in dogs whereby they first discovered this reflex. So they were ringing bells every time they are feeding the dogs, and for a certain duration of time. Afterward, one day, once they rang the bell, without giving the food, they found out that the salivation from these dogs has increased. And that's one of the response due to the link between hearing and the cerebral cortex with the salivary center, causing the secretion of the salivation. So salivation not only happen when there is food in the mouth, the higher mental, cerebral cortex, and other senses might participate as well in stimulating the center and stimulating the reflex of salivation. So after the chewing, mastication, and breaking down the food, mixing it with the salivary secretions, after that, once it is soft, then the food will be pushed as bolus through swallowing into the pharynx, or the beginning of the oropharynx. So here what happens is that the movement will start, and then there will be some adjustment within the pharyngeal region, because that food should not go up into the nasopharynx and nose, and should not go anteriorly to the larynx. So in this process, which we have described before, first of all, the soft palate will move upward, closing the nasopharynx region, preventing the food from passing into the nose. That's the first step in swallowing. And once the food is moved, at the same time, the larynx moves up, the epiglottis moves down, closing the larynx. So the respiratory tract is shut off, both from up and down, and the only tract available for that bolus is to go posteriorly into the esophagus. And of course, the beginning of this swallowing is voluntary, which is under control. The tongue, which is controlled voluntarily, pushing these bolus of food into the pharyngeal region. Once the food is in the pharyngeal region and it is the first swallowing happen, the rest of the movements are involuntary in the peristaltic movement in the pharynx and propelling the food into the esophagus, and in the esophagus the process continues propelling the food down into the stomach, which is all involuntary. So the only voluntary part is in the beginning in the oral cavity and the upper pharyngeal region in swallowing. So the pharynx, again, that we described before, the funnel shape structure, which is consisting of the nasopharynx, oropharynx, and hypopharynx. So here you can see the part which are shared between the respiratory and oral are the oropharynx and hypopharynx, while the nasopharynx is purely for respiratory system. So swallowing, again, as we mentioned, swallowed through the pharynx by 3 stages: voluntary by the tongue, the oral cavity, then the pharyngeal involuntary, consisting of the peristaltic movement, pushing the food into the esophagus, and then the esophageal stage of swallowing, passing the food down into the stomach. So both stage 2 and stage 3 are involuntary, while the stage 1 only in the oral cavity is voluntary. Okay. It is also important to remember that the adjustments that happen. So once the food is about to be swallowed, the 2 things will happen to isolate the digestive tract from the respiratory tract, which is the movement of the soft palate closing the nasopharynx region, and the movement of the larynx and the epiglottis closing the laryngeal region, preventing food from entering to the respiratory tract. So here this figure also demonstrates the process of swallowing of food that passes from the oral cavity down into. So the most important step in swallowing is the beginning, whereby several adjustments will prevent the food from going into the wrong track, making sure it goes into the esophagus. Once it's in the esophagus, then autonomic function of peristalsis will push that food into the stomach, and afterward everything is going to be automatic by the autonomic nervous system. So the process of movement or peristalsis, which happens within the gastrointestinal tract, is mainly through formation of a ring of contraction, followed by a place of relaxation. And this segment will move only in one direction. So the food which is moved by peristalsis only moves downward, okay, toward the large intestine out through defecation. And even sometimes in special conditions whereby people suffer from very active gastric motility, of the treatments, which is surgical, they will take a piece of the small intestine and revert it. So this revert piece will cause a reverse peristalsis that slows down the movement of food within the gastrointestinal tract. So that movement usually happens in one direction, pushing the food from the upper down to the small and large intestine, which is preceded by contraction, followed by relaxation, and making that bolus of food move in one direction through the digestive tract. So we are not going to explain each part of the gastrointestinal tract, the walls, what are they, but in principle, which is the generalized description of the structure in the wall of the gastrointestinal tract, we have these 4 layers. Okay, we already know the first layer down, which is in contact with the food, is the mucosa. Okay, And in the mucosa, we have a special epithelium which is unique to the organ, okay? So in the mucosa, we have 3 layers inside. The epithelium, which is in direct contact with the inner lumen. Then below the epithelium, we have the lamina propria, which is a connective tissue layer. And there is a thin, insignificant muscle layer within the mucosa that presents in the gastrointestinal tract. Then that's the mucosa, and below the mucosa, or we are moving outward, from inner outward, the first in the innermost is the lumen. Surrounding the lumen is the mucosa. Surrounding the mucosa is the submucosa, which consists of a connective tissue layer with rich lymphatics and blood vessels with nerve fibers. Okay. Then after the submucosa, we have the muscularis externa, a muscular layer of smooth muscle. In general, we have 2 layers, circular and longitudinal, inner circular usually and outer longitudinal, and these 2 participate in the segmentation and peristaltic movements in the intestine. And then in the outermost region, we have a connective tissue cover known as the serosa, okay, which is the visceral peritoneum. So here again, as you can see, so this section of the intestine, so this is the part of the small intestine. What can you see here is that the all walls of the or layers within the wall of the intestine, and you can see here the connective tissue layer that is surrounding the digestive system. So that part, if you can see it in the figure, the mesentery. What is the mesentery? So basically the mesentery is a part of the connective tissue peritoneum, which is within the abdominal cavity. And during the development, most of the digestive organs are formed outside the abdominal cavity. So while they move into the abdominal cavity, they will take part of the peritoneum with them, and that part will be running around them. So they are basically from the back coming into the abdomen and taking this layer of peritoneum around them. So this layer will circulate around them, and it will meet in the posterior aspect, making the mesentery. So the mesentery is the attachment in the posterior aspect of the different digestive organs, connecting them to the posterior abdominal wall. I'm talking about the mesentery. One of you is asking. So the mesentery is actually the peritoneum, which is the lining of the abdominal cavity. So how is it formed? Mesentery is like a flap of connective tissue which contains lymphatic vessels, and it has an immunological function. And these, in addition, of course, the blood vessels penetrate and run through these mesentery. The mesentery is actually formed by the peritoneum that is pushed once the digestive organs during development, embryonic development, start to protrude into the abdominal cavity. This will be wrapping around them and making this double layer in the posterior aspect that remains attached with the posterior abdominal wall. So this attachment between digestive organs to the abdominal wall posteriorly is known as the mesentery, while there is a double flap of this mesentery in the anterior aspect of the abdomen that is known as the omentum. So we will describe it later. These are layers of connective tissue that have no role in digestion. Their role is primarily for connecting, protection, containing lymphatic vessels, even storage of fat. In addition, happens within these parts. So from outward, we have the serosa and the muscularis layer, which, as I mentioned, the 2 inner circular, outer longitudinal, and then the submucosa, which is a connective tissue with blood vessels, nerves, and lymphatics, and the mucosa, which is the innermost region consisting of circles known as the plica for single or plici for plural of these circles, which are like sphincters that are involved in the segmentation of the walls of the small intestine. Now these plica exist in the small intestine only. They are not present in the stomach or in the esophagus or in the large intestine. They are exclusively present in the small intestine. So this section here showing a section of the structure of the small intestine. And then within that fold, which is a circle running through the circumference of the intestine, from it there are some finger projections. These finger projections are the villi. And we know these villi and microvilli are important to increase the surface area in favor of absorption. So this is the general histological appearance of the wall of the gastrointestinal tract. The one which is shown here is basically the small intestine. Okay? So we have described the oral cavity, the teeth, the salivary glands. We have described the process of swallowing. And now we have reached into the esophagus, which is a muscular tube. The length of that tube is 25 centimeter. The diameter is 2 centimeter. And it extends from the pharynx, the lowermost, the laryngopharynx, down to the stomach. And as I mentioned to you, it doesn't secrete any digestive element. It mainly, the function of it is to propel the food from the pharynx through peristalsis into the stomach. Okay? So in this part, which is mainly conducting the food down to the stomach, we have two sphincters. Sphincters are circular arrangement of smooth muscle which has some tone that prevents the movement of food bolus through it. We have one that exists in the lower part of the esophagus, between the esophagus and the stomach. That is the lower esophageal sphincter. And we have one above between the esophagus and the pharynx. Okay, and that one is the upper esophageal sphincter. So the functions, I'm going to describe it in the next slide. So the functions of the upper esophageal sphincter is mainly to protect the airways. Here, sometimes if the food moves backward, okay, through reflux from the stomach to the esophagus, the upper esophageal sphincter will prevent that food, which is highly acidic and it has already burned the surface of the esophagus by the high acidity. It prevents it from reaching into the pharyngeal region, going back anteriorly to the larynx and respiratory system. So that's one of the rules of the upper esophageal sphincter. So protective rule for the respiratory system. While the esophagus itself, it moves, transports the bolus from pharynx to the stomach, and also clears the material reflux from the stomach. So sometimes in vomiting, which is a protective mechanism, esophagus also helps to reverse the movement of food to move upward to the oral cavity. We are going to describe later on this reflex, the vomiting reflex. So the lower esophageal sphincter, which is very important to protect the esophagus from the high acidic content present in the stomach. Okay, so both sphincters are protective, the upper and the lower. The lower protects mainly the esophagus, while the upper mainly protects the respiratory system. Here we can see one disorder called achalasia. Achalasia is a disorder of the nerve fibers that supply the smooth muscles of the esophagus, causing increased tone of the lower esophageal sphincter and accompanied by some dilatation of the walls of the esophagus, accompanied by difficulty in swallowing, acidity, epigastric, chest pain sometimes, okay? and it is also precancerous. It can lead to malignancy. So this is one of the disorders that happens due to problems in the nerve and the nerve fibers supplying the walls of the smooth muscles. Okay. Another problem is the hernia. So hernia, we know it in Arabic, it is known as the fatiq. It happens in many parts of the, sometimes it happens through an incision of a surgery whereby a bulb of tissue passes through some defect. Here also, there is a certain weakness of the diaphragm. By the way, the lower esophageal sphincter, as you can see in the upper part here, that lies between the esophagus and stomach, it consists of two elements. One element belongs to the lower esophagus, okay? The second part belongs to the diaphragm. You know the diaphragm is a respiratory muscle. Diaphragm also adds more strength to the sphincter by guarding this region. Sometimes the weakness in this crural part of the diaphragm causes the bulging of part of the stomach upward above the pharynx. Normally, the stomach should all stay below the pharynx and it never goes up. But in hiatus hernia, weaknesses in the diaphragm causes part of the stomach to push upward, passing through the diaphragm, and this will mainly decrease the lower esophageal sphincter, because we know the part of the lower esophageal sphincter depends on the strength of the diaphragm. So this will cause the reflux of food into the esophagus, okay? So it's a structural abnormality in the superior part of the stomach, protruding above the diaphragm. It weakens the sphincter, causing the reflux of gastric juice into the esophagus. Of course, it will burn the mucosa of the esophagus, causing the heart burn, which we all see in the advertisement about the drugs used to elevate, because it's a very common problem, and it mainly it has some genetic or pathological causes, but it also happens due to stress, unhealthy lifestyle, obesity. The type of food also can increases the risk of reflux. So that's why we see a lot of advertisements about the reflux and the heartburn that happens after eating, okay? And the treatment usually involves restricting food intake, avoiding heavy meals, avoiding dinner, try to eat very little at night before sleeping, okay? Taking antacids to reduce the acidity so that when any reflux happens, it's not going to damage the esophagus or the upper respiratory tract. Sleeping with head elevated. Sometimes even the beds are modified in order to prevent the acid from going up. Hernia is protrusion. Protrusion. So we have inguinal hernia, one example. We have abdominal hernia. We have different types of hernia. But here the only one we are describing is the hiatus hernia, which is happening due to the weakness within the diaphragm, so causing this protrusion. Okay? All right. Sometimes if the hernia of the small intestine can even, you can imagine if there is a, we know that in the abdominal cavity, the anterior portion of the abdominal cavity is covered by different layers, including the skeletal muscles. Sometimes in surgeries that includes incisions within the abdominal cavity will make some weakness. Then that weakness will be protruded. So you will find like a balloon coming out from the abdomen through that site, and that balloon will bulge with coughing and straining. And sometimes it might include part of the peritoneum, part of the intestine, which might also go into gangrene, and it needs a very surgical emergency, okay? So those we are not discussing. We are only discussing one type of hernia, which is the hiatus hernia that happens in the diaphragm. And that one includes part of the stomach, which is the herniated part. So this is the hiatus hernia that is passing through the diaphragm. So again, we reach into the esophageal sphincters. As we mentioned, the upper esophageal sphincter prevents air passing to the GI tract and preventing contents of the GI tract passing into the respiratory system. The lower esophageal sphincter prevents acidity or acidic gastric juice from reaching into the esophagus. Okay? And we know the problem of gastroesophageal reflux disease. And for short, it is known as GERD, G-E-R-D, GERD. So gastroesophageal reflux disease is a disorder caused by a relaxation of the lower esophageal sphincter. Now, this relaxation can happen due to stress, psychological issues, type of food. I remember some examples like coffee is known to relax the lower esophageal sphincter. Chocolate as well also relaxes the lower esophageal sphincter. So these type of food might cause decrease in the tone of constriction in the lower esophageal sphincter that might allow the passage of gastric content into the esophagus, and the esophagus is not prepared for that high acidity. Only the stomach can tolerate the high acidic environment. So that acidic component, once it reaches to the esophagus, it will cause this burning sensation, and that burning sensation treated usually by adjusting the lifestyle, the food, how we sleep, how we eat, some medication to reduce the acidity. Okay. By the way, overweight also can increase the chances of GERD, gastroesophageal reflux disease. And by the way, if GERD continue for a long time, then it might cause also metaplasia, change in the layer of epithelium surrounding the esophagus, which is non-keratinized stratified squamous epithelium. Okay, so it will change by the high acidity of the environment, which is not normal to be existed within the esophagus. And that, of course, metaplasia is a pre-cancerous, it's a pre-malignant condition. So the stomach. The stomach, after we have talked about the esophagus, functions of the stomach, storage, storing the food, mainly in the part of the stomach which is, I'm pointing now, is the fundus. So this part of the stomach is known as the fundus. We also have the fundus in the uterus. So this part is mainly for storage of the food. In addition, mechanical, we talked about the grinding, the peristalsis, the chemical digestion by the enzymes, the acids which are released into the lumen of the stomach. Very, very little absorption happen for fat-soluble substances happen within the stomach. And the stomach has a smooth anterior and posterior surfaces. From the front and the back, it is very smooth. The fundus is here. I'm pointing to it. It is the rounded bulge of the stomach, which is in attachment with the diaphragm. I'm using the pointer right now. So looking into the figure, I'm moving it right now. The part of this is the upper part of the stomach, which is above the lower esophageal sphincter in contact with the lower surface of the diaphragm. This round part, which is part of the stomach, is the fundus. Okay? So the stomach has the anterior and posterior surface, which are smooth. We have this outer curvature, which is called the greater curvature. And we have the one which is a smaller curvature to the, like a bean. Okay, the bean or a letter C has an outer curvature and inner curvature. In the stomach, the outer curvature is the greater curvature, while the lesser curvature is on the medial aspect. Okay, and attachment with the medial aspect by this flap of connective tissue, the peritoneum, which is known as the omentum. Here in the lesser curvature, it is known as the lesser omentum, while the attachment in the greater curvature by this flap of peritoneal tissue layer, okay, is known as the greater. It is larger in size and it runs in the front of the abdomen. So this is the first part that will appear covering the small and large intestine in the anterior aspect of the abdominal cavity. Okay? And as you can see, blood vessels, storage of fats, lipid droplets are here, in addition to special lymphatics that has an immunological function are also present here. So what is also unique in the stomach is it has a special mucosa and special folds of mucosa inside it known as or roga for single. We will show it in the next slide. And we have also special gastric pits, which are special grooves that are mainly important for the secretion of gastric acid into the lumen of the stomach. In addition, one of the differences of the stomach is the presence of 3 layers of smooth muscle instead of 2 in most of the GI tract, because the stomach is associated with a strong mechanical churning that causes the breakdown of food particles. So strong mechanical and strong chemical digestion of food happens in the stomach. So one of the differences, as I mentioned, is the additional muscle layer that's only present in the stomach. So anatomically, the stomach is divided into this region. The upper one here, you can see it is highlighted, the fundus. Then below the fundus is the body, or the body is the main part of the stomach. The part of the stomach which is joining the esophagus, that part is called cardia. Now cardia, we also use the word cardia for the heart, cardiac problems, okay? Cardia here also is used to refer to the beginning of the stomach, or the part which is joining the esophagus. So the lower esophageal sphincter is also known as the cardiac sphincter for that reason, because it joins the esophagus with the cardiac part of the stomach. So the fundus, the cardia, the body, the lesser curvature, the greater curvature, then the lower part, which is slightly horizontal, that part, the beginning of it is known as the antrum, okay, the pyloric antrum, followed by the pyloric canal and pyloric sphincter. So this is another sphincter. So the stomach is having a sphincter above with the esophagus, and it has a sphincter below with the duodenum. Now that will close while the stomach is digesting the food. Both sphincters will be closed, okay? And the stomach will be grinding, churning, chemically breaking down that food in digestion while in the first stage of digestion of the food particle. So the pyloric is the last part of the stomach, as we have just mentioned, and the characteristic mucosal fold known as rugae is also one of the characteristics of the mucosa within the stomach. So here you can see the esophagus, the fundus, the body, the antrum, and here is the pyloric region, pyloric canal, and the pyloric sphincter joining here to the duodenum. So in the duodenum, the environment of the food is going to be very different. It's not going to be acidic anymore due to the secretions of the glands that secretes bicarbonate and alkaline secretion that will neutralize the acidic content coming out from the stomach. Here there is another figure showing you the stomach, a real cadaver. So you can see the greater curvature, you can see the lesser curvature, we can see the greater omentum, the lesser omentum, okay? pyloric canal, pyloric sphincter, and the duodenum. You can see it here. So here, another look into the internal structure of the stomach. So you can see the folds of the mucosa, which are known as the rugae. So these rugae are the special folds of mucosa within the stomach. So the lower esophageal sphincter or the cardiac sphincter prevents the reflux of the gastric content into the esophagus. The pyloric sphincter, which is after the pyloric canal, connecting the pyloric canal to the duodenum. Pyloric canal is the part of the stomach. So it is relaxed and open when the stomach is inactive, passing the food downward through peristalsis into the small intestine. Okay, the differences, as we just mentioned, in the folds and the muscle layer. So the additional layer of muscle and the strongest part of all these layers is the circular, which helps in the churning movement and digestion of food. So what are the glands that are present within the mucosa of the stomach, or the gastric glands? So here, these glands are not present on the surface. Why is that? Because of the high acidity in this region. So the high acidity here, of course, there is a lot of secretion in the mucosa of a mucus, and this mucus will help to protect the mucosa of the stomach. At the same time, there is an increase, there is these special pits within the gastric mucosa, which is guarded by the mucus, and this duct-like structure is lined by different secretory cells. Now, in the upper part, mucus, neck cell that secretes mucus. In addition, we have the important secretory cells of the stomach. One of them is the parietal cell. So the parietal cell secretes hydrochloric acid and intrinsic factor. Hydrochloric acid, that HCl, which is important for denaturation of protein, and it has an antibacterial function, kills all the bacteria. In addition, it helps in activation of the pepsinogen, the protein digesting enzyme, which is also secreted by the Chef cells in the stomach. Intrinsic factor is important for the absorption of vitamin B12 that happens in the terminal ileum, which is the last part of the small intestine. So the factor is secreted by the parietal cell. So Chef cells secrete pepsinogen, as I told you. This pepsinogen will be activated. What is the pit? The pit is this gastric pit, is the canal shape. A pit is like a groove, like a canal, which is through the mucosa. So these cells are not outside in the mucosa in direct contact with the secretion in the stomach. They are protected, and their secretions, their environment is very alkaline by the mucus, by the bicarbonate that protects them from the acidity upward. So on the surface, there is a gradient that goes from alkaline to neutral to high acidic in the lumen. Okay, so this pit or groove contains all these secretory cells. We have already mentioned the mucus cells and the neck region. We have described the parietal cell. In addition, we have the Chef cell that secretes pepsinogen. Pepsinogen is the inactive protein digesting enzyme that is activated by hydrochloric acid once it's reached. So once it is in the pit, it doesn't have any function because it's inactive. Once it's in the lumen, in contact with the acid, it will be activated and it will start protein digestion in the stomach. We have a group of cells known as enteroendocrine cells These are endocrine cells secreting gastric hormones. One of them is the G cells secreting gastrin. Gastrin hormone is released by these enteroendocrine cells in the stomach, and this hormone is conducted by the blood circulation, and it induces increased motility of the stomach, increasing the secretion by the stomach. Okay. In addition, we have enterochromaffin-like cells secreting histamine. Histamine also plays a role in the secretion or stimulation of the parietal cell function in the stomach. So you can see here another table showing you the group of cells. So it is important to remember the type of cells within the stomach, the parietal secreting hydrochloric acid and intrinsic factor. So intrinsic factor important for the absorption of vitamin B12, while hydrochloric acid is important for the activation of pepsinogen and digestion of protein. Scheffer cells secrete pepsinogen, which is the inactive protein digestion enzyme that will be activated in the lumen of the stomach. Mucus cells secreting mucus and bicarbonate, which is very important to protect the mucosa from the high acidity by having this protective alkaline layer. Enteroendocrine cells secreting gastrin that enhances the gastric secretion and motility. Enterochromaffin-like cells, ECL, secreting histamine, which is also part of the cells that secretes this hormone, enhancing the gastric secretion and motilities. Okay. In addition, we have some stem cells which are highly dividing, replacing those cells which are damaged by the acidity or the digestive elements of the gastric mucosa. Some cells will be lost, although we have the protective mechanism. Yes, it includes all the cells in the stomach only. Yeah, it is enough to describe everything in the stomach. So in the stomach, we know now the different types of cells, and within the wall we have the rugae, we have the gastric pits, which includes the different types of secretory cells. So once the food reaches down into the stomach, then these secretions will be released from the stomach, and the stomach sphincters will be closed, and the stomach will be grinding, breaking down the food mechanically and chemically and enzymatically with all these elements that are provided by it. And once after the food is ready, then the pyloric sphincter will relax and a peristaltic movement will start moving the food or the chyme which is digested in the stomach to go into the duodenum, which is the first part of the small intestine. So part of the stomach physiology is that the secretions per day is around 2 liters, the gastric secretion. And the secretions are controlled by 2 mechanisms. One of them is neurogenic by the vagus nerve, which happens again in the same mechanism of salivation. So the same reflex through the vagus nerve also stimulates sometimes those people who have peptic ulcer or stomach ulcer. Once they think about food, they start to have stomach pain because of the increased secretion of hydrochloric acid in the stomach once they are thinking about the food. So this is one of the neurogenic mechanisms. Presence of food in the stomach itself, it also stimulates the neurogenic mechanisms. In addition, we have the hormonal regulation, as I mentioned to you, by the enteroendocrine cells that secretes gastrin, the enterochromaffin-like cells secreting histamine. These will also enhance the stomach or the gastric secretions. And as I mentioned, the stomach function is mainly for digestion. There is very little absorption here for highly lipid-soluble substances, such as some medications and alcohol that could happen through the stomach or the gastric mucosa. So the phases of gastric secretion again, which also describes the regulation. The first one is the cephalic, the head, which is similar to the neurogenic by the vagus nerve. So thinking, seeing, smelling, okay, this will all increase the secretion, okay? And we have the next is the gastric phase. While the food is in the stomach, the direct contact will cause the stimulation of gastric phase through the local nervous and secretory reflexes, the vagus nerve, the gastrin, histamine stimulation. So this will enhance the secretory function of the stomach. And then lastly, the intestinal phase. Once the food is in contact with the intestine, so this will enhance the motility and reduces the secretion of the stomach to cause the emptying of the stomach into the small intestine. And this is also regulated hormonally by other groups of gastrointestinal hormones and with the involvement of the nervous mechanisms by the vagus nerve. So here the gastric secretion, and this is the gastric pit that we have just described. Hydrochloric acid. So we are describing now what is the protective mechanisms against the highly acidic environment. So hydrochloric acid secreted by the parietal cell. We know it is very traumatic and damaging to the mucosal layer. So but this is very important for activation and for digestion. Proteins are first are deteriorated or damaged, broken down by the acidity. We call it denatured. One of the mechanisms of denaturation of protein is by pH. So hydrochloric acid will cause the denaturation and the breakdown of protein molecules. It also activates the protein digestion enzyme known as pepsinogen that will become active while it is in contact with the HCl, and the name becomes pepsin. So what are, this figure here shows you the mechanism of secretion of hydrochloric acid. You don't need to draw or remember the components inside this figure. Only I want you to focus about one part. So you can see here, chloride ion, which is one part of the HCl, is in beginning exchange through an anion exchanger with bicarbonate, by which it enters to the parietal cell from the blood, and then it leaves through a special diffusing channel. While the hydrogen atom, which is the most important part, is pumped out. It is generated through the same mechanisms of binding with CO2 that you already know. CO2 with water, carbonic acid, and hydrogen and bicarbonate. Remember those which we have described before? So the hydrogen will be pushed through a special pump. So this pump will use energy in the form of ATP, pumping hydrogen outward, and this hydrogen is the part of acidity. Okay? So that's why when we are taking medication to treat ulcers in the stomach or in the duodenum, we use drugs that target this pump. And these medications are referred to proton pump inhibitors. I'm sure some of you might hear about it, or you know a family member who's suffering from stomach problems. Omeprazole is one of the medications, those drugs that inhibit these pump and inhibit the secretion of gastric acid by blocking this pump that releases hydrogen. So that's only what I want you to remember from this figure. So what is the mucosal barrier? What is the protection? If I ask you, first of all, you need to know that we have the mucosa. Yes, the gastric mucosa, yes, it is in the stomach. Okay. This is also in the stomach, the parietal cell. This is inside the gastric pit. Yes, it is also. This is where the HCl come out, only in the stomach. So this is the parietal cell. which is one of the cells in the gastric pit, secreting the hydrogen and chloride, HCl, that will be propelled out into the lumen of the stomach. So the protections come from the mucus, from the bicarbonate that will maintain an alkaline pH on the surface of the cell, preventing the breakdown or the digestion of living cells within the mucosa of the stomach. In addition, we have tight junctions between the cells that will prevent the penetration of the hydrochloric acid. So the bicarbonate, the mucus, and the tight junctions together will make the mucosal barrier. And this mucosal barrier is very important and crucial to prevent gastric ulcers. So that's why in certain conditions, due to infection and due to high acidity or due to factors, this layer might be disturbed, damaged, causing the ulcers. And the ulcer is loss of the epithelial lining due to some external agents. And here, the ulcer is due to the gastric acid, which is very damaging and traumatic, as I told you before. So vomiting, which is one of the protective mechanisms. So if we try to remember, vomiting is usually preceded by many stimuli. We know about sometimes some people hearing some bad news, feeling very depressed, and then they go and vomit. Sometimes you smell something that irritates and it makes you feel you want to vomit. Sometimes pregnant ladies in morning sickness, they also vomit. Some people with ear problems, they tend also to vomit. Sometimes if you eat something which is contaminated, okay, it might also be followed by vomiting. And we all remember the sequence of vomiting whereby all the content of the stomach will be coming out up through the esophagus into the pharynx from the mouth, okay? And we remember the abdomen muscles are contracting in a very powerful way, pushing the content, okay? We also feel this abdominal pain, and the abdomen is trying to press the stomach, squeezing the content, and in addition, there will be relaxation of the lower esophageal sphincter and reversal of peristalsis. So instead of the normal peristalsis that moves the food up, down, the peristaltic movement will be reversed in vomiting. And the relaxation and squeezing by abdominal muscles all will push the content from the stomach outward. Okay? So what are the stimuli? Higher cortical functions, memory, fear, sadness, pain, smell, sight. Sometimes you see something that makes you nauseating and you vomit. Some neurological problems. People with neurological problems commonly have vomiting. Those who have cancer in the brain and irritation of the nerve tissue can easily cause stimulation of the vomiting center in the medulla. In addition, some irritant or chemical receptors within the stomach. If the food is contaminated, the food is not a clean food. It's causing food toxicity. So what happens is that the stomach will make action to move it out from the upper GI tract and not allow it to move into the duodenum. So the pyloric canal, pyloric sphincter will constrict. The stomach will go through reverse peristalsis with the esophagus and pharynx. The upper esophageal sphincter will relax, and the abdominal muscles will squeeze the abdomen, and this will squeeze the stomach, and this pressure increase will push the content of the stomach upward through the esophagus out from the mouth through vomiting. So another disorder, gastric and duodenal ulcer. So an ulcer is as you can see in the figure, is loss of continuity of the epithelial lining. So in the upper gastric tract, we have gastric and duodenal ulcers, which differ in their presentation, the symptoms they have. duodenal ulcer tend to become more common than gastric because the duodenum, as we know, is prepared for the high acidic content that comes from the stomach. Okay? There is a problem with the sound. Is it okay? You can hear me well? Okay, good. Okay, so these ulcers, which are loss of the mucosal lining within the stomach or the duodenum, Kauthar cannot hear. Can you hear now? I see the movement of the microphone. Probably you have something with the speakers or the sound. Anyway, so the gastric and duodenal ulcers are the loss of continuity of the mucosa or the epithelial lining due to some damage, and that damage is mainly caused by infection with some kind of bacteria known as the H. pylori. Now, this bacterial infection interferes with the mucosal and protective mechanisms within the mucosa of the stomach or the duodenum, in addition to the increase of the effect of the hydrochloric acid. Now, what are the factors that increases the risk of these ulcers? Smoking. Very commonly, those who are smokers, they have these problems. Alcohol can also increase the chances of ulcers. We call these ulcers peptic ulcers because of they are happening in tissues under the influence of pepsin, or which is including the stomach and the duodenum. What else? Drugs like non-steroidal anti-inflammatory drugs. One example is aspirin, Voltaren. Those painkillers can also be very damaging for the stomach. So if you have headache and you have stomach problems, it's better to avoid those medications. Try to use an alternative analgesic that does not increases the stressful events on the stomach. Stress by the cell, if you are moving through stress, it can increase the acidity and increases the chances of developing ulcers. Ulcers are very dangerous. It can lead into perforation of the wall. It can lead to severe bleeding, scarring that leads later on to obstruction, acute abdomen, peritonitis. All of these complications can happen due to ulcers. One of you asks, like what? What do you mean, like what? Drugs. Yeah, I just mentioned to you. Non-steroidal anti-inflammatory drugs. Aspirin, Voltaren, what else? Those groups of medications that are anti-inflammatory analgesics. By the way, paracetamol is not like that. Paracetamol does not have that effect. So usually if you have any pain and you have a stomach problem, then you better use paracetamol and stay away from other analgesics that could increase the acidic secretions. Yep. So usually the treatment, if somebody have a gastric or a duodenal ulcer, is use H2 blocker. So remember the slide I showed you about the parietal cells and the proton pump? So those proton pump will inhibit the H2 blockers, or the proton pump inhibitor will block this pump and prevent acid from being secreted. And this will reduce the symptoms of ulcers. Antacids, these are some, in chemistry, when acid reacts with a base, it forms water and salt. Okay, so we use alkaline materials or that will neutralize the acidity in the stomach, but those are very temporary, not like the proton pump inhibitor that will stop acid secretion. If you are using antiacid only, the acid secretion will continue, and this will neutralize the acid. It will react with the acid and neutralize it, changing it into salts. Antimicrobial therapy is also very important to eradicate the H. pylori bacteria, which is one of the predisposing factors for the peptic ulcer. So usually people with ulcers, if you look into their treatment, you will find a combination of antibiotics in addition to the antacids. By the way, one of the antacids is antihistamine. Antihistamine medication on the stomach can interfere with, as I show you, the ECL cells, enterochromaffin-like cells, that secrete histamine and stimulate the gastric secretion. Medications, the antihistamines that, I remember one medication, I forgot the name, Tagamet, cimetidine, okay? That medication that inhibits the enterochromaffin-like cells and inhibits the acid secretions from the stomach. So cimetidine, ranitidine, those medications work in that way. So that's all what we know. By the way, presentation of ulcer is usually pain that happens when the stomach is empty or when sometimes you are eating. That's the difference between gastric and duodenal. Some of these, the gastric pain is increased, gastric ulcer increased when you eat food, while duodenal ulcer, the pain is relieved when you eat food. Gastric ulcer could be relieved by drinking milk. Same goes to duodenal ulcers. Presentations are these burning pain, okay, that happens in relation to food. So we reach into the small intestine. We will go through slightly part of it. So the small intestine consists of these the smaller portion in the beginning known as the duodenum. So the duodenum is the first part of the small intestine, which is the part involved in peptic ulceration because it is the first part to receive the gastric content, while peptic ulceration is less likely to happen in the jejunum or in the ileum. Okay, so the duodenum is the 25 centimeter in length, and in the duodenum the function is mainly digestion. So here, in the duodenum, secretion of other digesting elements. So the food or the chyme which has just been in the stomach is going to be further digested by more enzymes secreted from the duodenum. Not only the duodenum, but there is one special thing in the duodenum. You are aware that we have accessory organs such as the liver, the pancreas, the gallbladder. Those organs will secrete their digestive elements into the duodenum. So there are special ducts that will empty their contents of enzymes into the duodenum. So the duodenum secretion, part of it comes from the duodenum itself, and majority of it comes from the liver, from the pancreas, the gallbladder, and all of these contents are alkaline. So they will neutralize the acidity of the chyme coming, or the food which is digested coming from the stomach with high acidity. So here mixes the chyme with these coming from the stomach with exocrine secretions of the pancreas and liver, in addition to the secretions from the duodenum itself. Starting from the jejunum, here absorption starts. So chemical digestion continues and absorption occurs. And in ileum, here continues the process of absorption until reaching the ileocecal valve, which is the joint between the small intestine and the large intestine, which is, if I'm following the pointer, is located here. And it is the same location where the appendix exists. Okay? So this ileum, which is 3.5 meter, so you can see the duodenum is very short, 25 centimeter, while the jejunum is 2.5 meters, the ileum is 3.5 meters, and here both of the jejunum and ileum are main sites of absorption. Okay, and these will push the food into the large intestine. So in the large intestine, there is no more digestion and there is only absorption. Okay, but the most of the absorption happens in the jejunum and ileum. The digestion continues between the duodenum and the jejunum. In the ileum, very little digestion continues here. Mostly absorption in the jejunum and ileum. Majority of absorption happens in these two parts, which is the majority of the small intestine. So the liver, as you can see, there are some ducts known as the right and left hepatic. Hepatic refers to the liver, so left and right hepatic duct, making the common hepatic duct that will join the duct coming from the gallbladder. The gallbladder, we know it in Arabic as the marara, okay? So here the secretions from the cystic duct, which is the duct coming from the gallbladder, will join the common hepatic duct, making the common bile duct. Now this common bile duct, which transports or conducts the secretion from the liver and mainly from the gallbladder, which stores and concentrates the secretion of bile that comes from the liver. By the way, bile which comes from the liver is stored in the gallbladder and it is released in response to digest fat. Bile is very important for digestion of fat. Okay, bile acid, bilirubin, okay, which is the end product of hemoglobin digestion. So here the content will be into the common bile duct that will join the pancreatic duct and open into the second part of the duodenum. So the first part is here, second part is where the content of the common bile duct and the pancreatic duct open through the ampulla of Vata or the sphincter of Oddi. So this pancreatic sphincter or the sphincter over here controls the secretion, and usually this secretion is not all the day. It happens once the food is pumped out from the stomach into the intestine. So once the fatty acids, the proteins are in contact with the duodenal mucosa, this will enhance the secretion of special enteroendocrine cells that will stimulate the secretion from the gallbladder and the pancreas. Example is the hormone known as cholecystokinin pancreozymin. This hormone enhances the secretion and the contraction of the gallbladder, releasing the secretion to the duodenum to digest the fatty acids and proteins. So fatty acids digestion is from secretions from the small intestine and from secretions from the liver and from secretions from the pancreas. In addition, proteins digestion, carbohydrate digestion also continues in the small intestine. So all the secretions from the intestine, from the pancreas, from the liver, from the bladder will play a role in digestion in the duodenum. So back to the duodenum, which is the first part of the small intestine. Here the common bile duct and the pancreatic duct, as I told you, will open up to the duodenum through the hepatopancreatic ampulla. The other name is the ampulla of Vata. Okay, and that ampulla will open into the duodenum, and there is a sphincter. That sphincter is the hepatopancreatic sphincter or sphincter of Oddi. Okay, I know it for the name sphincter of Oddi and the ampulla of Vata. So these are other names. So there is a sphincter and there is papillae or ampulla, whereby the secretions will be leaving the common bile duct and pancreatic duct. So secretions from the pancreas and the liver, the gallbladder, will go into the second part of the duodenum, mixing with the food which is already being digested by the stomach. And the digestion continues mechanically and chemically and enzymatically. So here, this is the section through the small intestine, and the functions here are listed. So mainly the function is secretion of intestinal juice, which are important for the process of continuing digestion. That is under the parasympathetic stimulation. By the way, most of the gastric functions are controlled through the parasympathetic system. The sympathetic stimulation will inhibit motility and digestion of the gastrointestinal system. So most of these functions are parasympathetic reflex function. So secretion is one of the functions in the intestine. Movement of the food particles through peristaltic movement, in addition to the segmentation, which is another function that happens in the intestine, whereby mechanical digestion continues. So the secretion, the motility, the mechanical breakdown are all under the control of the parasympathetic system. And in addition, the completion of the chemical digestion of carbohydrate, protein, and lipid happens in the intestine. Absorption starts in the intestine. Immunological part by Peyer's patches, which is lymphatic tissue, that will guard the small intestine. So these are all functions of the small intestine. So if we make a comparison between the intestine and the stomach, both of them participate in digestion. Both of them participate in absorption. Stomach has very little absorption compared with the intestine. And the stomach also is mainly for the digestion of protein, while the intestine mainly continues with the absorption of fat, carbohydrate, and protein. So here the movement in the small intestine, we have the two types, the peristalsis, which moves the particles in one direction, and the segmentation, as I explained to you, that helps in continuing physical breakdown of the food particles or the food bolus. So talking about the secretions from the pancreas, I think this will be the last part. I'll talk about the accessory glands of the pancreas and the liver, and then I will leave the rest for next lecture. So the pancreas is a mixed gland. It has endocrine part and it has exocrine part. The endocrine part is the, you know that insulin, glucagon, these hormones are secreted by the pancreas. So that's why pancreas is an endocrine gland, because it has these ductless glands or parts which release hormones directly into the blood. In addition, there are parts of the pancreas which are with ducts, and these are called the exocrine acini. These exocrine acini will release exocrine secretions that will go through the pancreatic ducts into the duodenum. So the insulin, when it is secreted, it will not be released to the duodenum, although it comes from the pancreas. But that part is endocrine, go directly to the blood, while the parts which is going to be released from pancreas and reaching into the duodenum, that is the exocrine part only. So exocrine part only includes the protein and fat digesting elements that are present in the pancreas, in addition to the secretions that are coming from the liver through the gallbladder. Okay? So here this slide shows you the digestion of carbohydrates. So starch digestion by amylase starts in the oral cavity, as we mentioned before. In addition, we have another amylase secreted by the pancreas, known as the pancreatic amylase, continues with the digestion of starch, changing it into disaccharides and oligosaccharides. Dextrins, maltose, maltotriose, these are oligo and disaccharides. Now, we have a group of disaccharide-ases, enzymes that will break down these smaller molecules, and these enzymes are released by the mucosa of the small intestine. So these will break down the large carbohydrate molecules to glucose, which is a monosaccharide. We have another disaccharide like lactose. So the enzyme lactose is the milk sugar, and lactase is a disaccharidase like those, like maltase, a disaccharidase enzyme released by the intestinal mucosa breaking down the lactose into glucose and galactose. Both of these are monosaccharides, but with different chemical structure. Sucrase is another disaccharide. Sucrose, by the way, is table sugar, the sugar that we use with tea or with any juice that we make. So this will be broken down by the sucrase, okay, into fructose, which is the fruit sugar, another monosaccharide, and glucose. So this digestion, part of it happens in the oral cavity, and most of the remaining part happens in the small intestine by these disaccharidase, oligosaccharidase enzymes breaking down all the complex big structures of carbohydrate into the last simple structure, which is the glucose. So glucose will not be broken down further. Our goal from carbohydrate breakdown is to reach it down to glucose. The glucose will be absorbed in the small intestine through a facilitated diffusion combined with sodium ion. Anyway, so glucose is the target. While, for example, in proteins, the goal is to break down the proteins into smaller units of amino acids. Fats or lipids will be broken down into fatty acids and glycerols, and those will be absorbed. So we break down the food through the digestion to make them reach into these smaller elements that can be easily absorbed. So protein cannot be absorbed. It needs to be broken down to amino acids. Starch will never be absorbed. It needs to be broken down into reaching glucose. Glucose is the only absorbable form of carbohydrates. Amino acids are the only absorbable form of proteins. Free fatty acids, glycerols are the absorbable forms of fats. Okay, so in digestion, in mechanical and chemical and enzymatic digestion, the aim is to reach into those smaller elements that could be absorbed from the small intestine. So here, protein digestion, of course, we remember the pepsin, which is released in the stomach by the Chef cells that will start the protein digestion into oligopeptides and aminopeptides. Okay, these are chains of amino acids. The oligopeptide, which is smaller than 100, it is called oligo. If it is more than 100, it is called a protein. So in addition, this is one important thing, by the way, because I think some of the questions are in this regard. So you need to know that protein digestion happens by enzymes secreted from the stomach, which is the pepsin, enzymes which are secreted from the pancreas, reaching into the small intestine, which includes the trypsin and chymotrypsin carboxypeptidase. In addition, enzymes which are released from the small intestine. And most of you make this mistake. So small intestine secrete enzyme also, not only the pancreas, not only the stomach. Stomach, pancreas, and small intestine all release enzymes that will break down these protein molecules into smaller amino acids. Stomach, small intestine, pancreas. So these are the three elements that participate in breakdown of the food. So here you can see this makes it very clear. So from the stomach, the pepsin, the hydrochloric acid, both of them will play a role in digestion. While in the small intestine, the pancreatic enzyme, trypsin, chymotrypsin, carboxypeptidase, these are proteolytic enzymes. And then in the intestine, the small intestine, we have the brush border enzymes that will be also released, aminopeptidase, carboxypeptidase, and dipeptidase. So all of these three steps are important. So we will reach to have amino acids, free amino acids. And we have 20 amino acids. Some of them are essential, some of them are non-essential. You don't need to know them, but these will be absorbed in the gastric mucosa of the small intestine. And I think lastly, the fat. So the fat absorption will be in the form of micelles by the bile salts released from the common bile duct that will break down the fat into fatty acid and glycerol, as I mentioned before. Then these will be absorbed and will combine with protein, making chylomicrons that will go through the lymphatics to the liver. And then the liver start to change them into acetyl-CoA or acetic acid, and then depending on the condition of our body, these fats, if we are in hunger and we are running out of energy and we don't have carbohydrate source in our body, then the liver will use that fat to liberate energy or ATP. Otherwise, if we have enough energy, we already are eating carbohydrates, you have a lot of glycogen in the body, then the acetyl-CoA will be used to synthesize triglycerides, and then the process of storage of fats starts over there, and all of the problems of lipids deposition, obesity, atherosclerosis will happen due to the more than enough energy state available and the overfeeding of fats and carbohydrates. By the way, not only fats will be stored as fat in our body, sugars, glucose, if they are not needed for energy, they will also be used to form acetic acid and acetyl-CoA that can be used to synthesize fat. So any excess of energy, we have more energy than we need, then we are going to change that energy into fat that will be stored without limits in the adipose tissue, causing obesity. So I think I will stop here. So thank you very much. And next lecture will be very short, less than an hour. I think it will be very short, even less than 30 minutes. So today's lecture was very long. I think it is better, so that next lecture will be very short, and we'll finish the gastrointestinal system, and will be followed by Dr. Hala with the explanation about the renal system, I guess. So are there any questions from your side? So this lecture, by the way, is recorded. It's going to be saved into the same part. You can reach into it and watch it later on. I have already attached the PDF version of this lecture. And thank you very much for listening. And how about the grades? Which grades? I think Dr. Hala is already sending you the updates. She already sent you a survey, and I think majority of you are recommending the survey, so that there is a new calculation of system whereby you'll have more marks for the assignments, the quizzes, and you're having the reduction in the final exam marks. Okay, so I think all of these are being posted on the in the announcement in Blackboard. I guess yes, it's approved. Yeah. If there is anything, you will be updated immediately through the Blackboard announcement. So thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.